So, and the topic of access to care, I think at least one of us should mention the EDS Society Provider Director, because that's really what I use for new patients and when they're coming in from out of an area and they need to find someone in their more local area. But if I'm speaking on the perspective of the United States, yeah, we do have some very unique and complex problems of their own, but they, we should understand how to work through it a little bit better. As a patient who is, and this topic comes up so much too, is like, where is the first place to start? How do I know symptoms are important, and where do I begin? I would always instruct any patient with the first time recognizing symptoms are starting piecing these pieces of the puzzle together. You start with primary care and hopefully avoid emergency room visits, but the primary care would be the gateway to other specialty care. And make the referrals as necessary. Or at least give some guidance if they can't access specialty care locally, then to go to larger centers. So we started the EDS clinic at Mayo Clinic in 2019. That was unique in a sense that it did have access to other subspecialties, and there are centers like this across the United States, in Colorado and Kansas City and Indiana, and now we're building at University of Virginia and others. Here's where I give the plug for the core network too. So if you have access to those resources through the EDS Society page, you can see what are those core networks throughout the United States where they may have access to multidisciplinary care, which is needed, as we know. Mayo Clinic, though, we had devised it as a consultative service, meaning which that we could go through a lot of diagnoses and a lot of new patients, but we were not able to do the ongoing long-term care. And so it's taking the good with the bad. We're able to provide more care to more patients and more diagnoses because we know access is limited, because if we have a small number of these centers, and we want to see as many patients as we can, and we had fairly good when we were at full steam, about 3 months, no more than 6 month wait. In some places we know it can go on for years. So that's good. The problem is, though, patients do need long-term care and they do need follow-up. So we have to take the good with the bad. So what do we do with the long-term care and follow-up? Well, at Mayo Clinic, we had to rely on resources like the EDS Society Provider Directory. So patients going back to Utah, who do I see? Where do I go? And I'm coming from Oregon. Because I can't possibly keep up with every provider. I mean, it's great to network at conferences like this. I do meet so many names and faces, and it's good to have access and relationships across the country. But truth be told, I just can't keep up with it possibly. So I know the EDS Society does a good job of procuring that. Having said that, though, for long-term care now, the United States is a little bit unique as well, because we're dealing with things like insurance. We don't have the socialized health care that would be providing government support as much. We have Medicare, Medicaid, but a lot of the insurance problems then lead to questions about, is genetic testing going to be covered? Is durable medical equipment going to be covered? Is prior authorization needed for certain procedures? And it may well be, and that's a headache for patients and providers alike. So on the topic of insurance, though, what we're seeing in the United States, too, is a growing number as a result of the complexities of patients and the limitations of providers, is that a lot of providers are turning to a cash-based model. And that's really, in a way to get the support that they need to really run a business as it is, to just support themselves seeing patients. Because these initial visits can be very long, drawn out, lots of medical history to go through, and insurance or Medicare, Medicaid just doesn't reimburse as it should for that time that is needed to adequately spend with the patient to understand the full background and scope of the problems at hand. So these cash-based models, yeah, they have some of their own benefits and disadvantages, though, too, because I mean, the clear advantage is if you can't pay for it, then what are you expected to do? One advantage, though, is that you can usually get the good care and the time that you need with the provider and ongoing care. So it's still all yet to be seen. A lot of the discussion we're having in this conference, too, about biomarkers and research and things like that will certainly help it, because maybe we don't have to spend so much time on the history. We can rely on more laboratory testing and give us better direction of where to go. So we're hopeful to see it through. One last plug I'll put up here too is the advocacy program, the ECHO program, which is actually just coming up next week with Maggie Buckley. So advocacy is a huge issue. We know all across the world. It's certainly an issue in the United States. Because patients who are coming to this brand new, they don't really know, but healthcare advocates are there to support and serve that role. Getting patients to either, if it's a center or at least to resources, understanding the quagmire of insurance and coverage and what may be in their best interest, what may be also local networks of care, whether it's physical therapy, occupational therapy, counseling, and such that may be in their area. So that's coming. I think there's still time to sign up for that. So I will end there on the United States and pass on to our European colleagues.